Autism spectrum disorder.
It's a condition which involves challenges with social communication skills, restricted interests, and repetitive behaviors.
There are 500,000 children on the spectrum in the United States alone.
That is 1 in 68 children.
Making ASD a serious and growing public health issue.
The financial and emotional tolls on families are great,
with parents incurring many out-of-pocket expenses,
as well as losing work hours and career advancements.
The cost is nearly 10 times more
than raising an average child.
With early access to treatment and care, we can significantly improve a child's outcome.
But access to effective interventions is less available for some,
especially families who are under-resourced.
We aim to change this situation.
We are AIRB!
We are AIRB.
Autism Intervention
Research Network
for behavioral health.
We bring community and academics together.
Our studies have targeted core impairments of social communication in home and school,
enrolling over 1,100 families and children in research. AIRB has been in the community for nearly 10 years.
We have been pioneers in the field of collaborating together in community settings
instead of research centers.
We work in homes.
We work in schools.
We teach skills and strategies to children and to those who care for them.
Our interventions are informed by you.
We listen to each other.
Together, we have pushed the field forward of increasing participation of under-resourced and underserved families in research.
And increasing outcomes for children, families, and teachers.
And improving research designs.
And bringing greater awareness to the community.
We are AIRB.
That's it for our housekeeping items. And now it's time to introduce my co-facilitator, Ms. Liz Rogers of Eastern Los Angeles Regional Center. And Liz has been a crucial partner of our network, bringing her expertise as an autism specialist at the Regional Center. Hi, Liz.
Good morning. Good morning. So we will hear a welcome message from our leaders, Dr. Connie Kazri, the principal investigator of the AIRB network, and Ms. Felika Jones of Healthy African American Families.
Great. I'm going to share my screen here. Let's see. Okay. There we go. Whoops. Okay. Go ahead, Felika.
Hello, everyone. Thank you again for some of you for the first time coming to this conference, and those that are returning, we thank you, we thank you, we thank you. So we are a team of researchers collaborating with communities to improve the lives of individuals with autism throughout their lifespan, emphasizing inclusion for those traditionally marginalized and minoritized. We do this in partnership between academic institutions, this on the left, as you can see, there's many, and then the community partners that are on the right side of your screen. We use a model that's called community partnered participatory research methods. It is important to advance in the field of science. This is not a top-down approach. This is a bottom-up, top-down. We're equal partners in every phase of our partnership. It was developed by the late Dr. Loretta Jones, which also was my mother, with Healthy African American Families, but also in partnership with a lot of other community agencies and academics that were at the table in terms of building that new model. It's a strength-based approach, collaborating with communities to have strength and bring out the voices of what's going on in their communities, and to also help researchers to better understand what's happening, how they can better strengthen their approaches when they're working with community at large. This is a balanced academic goals to bring the win-win for everyone involved. Thank you.
Great. And over the years, we've conducted a lot of different research studies together. And here we show some of our recent ones. In general, we're trying to understand the experiences of parents and teachers, providers, the autistic individual as they navigate community services. And our goal really is to provide new knowledge that can improve access to effective interventions and supports. So one paper listed here was by a UCLA graduate student who's also doing our Spanish translation today. This paper just won the top research award for Division H in the largest educational research society, AERA. So congratulations, Fernanda. A main activity of our collaborative group is this annual community conference, and this is our 10th year. So some themes are listed here, but today's theme comes from our community partners who wanted more information on co-occurring mental health issues for autistic individuals. So we're very happy today to welcome you to our 10th annual conference promoting positive mental health in autism. Thank you.
Thank you, Connie and Felica, for the welcome message. Now we're going to get into the main content of the conference, autism and co-occurring conditions. First, we're going to learn about anxiety and ASD. Liz, could you tell us about our speaker?
Certainly. So we have Dr. Patricia Renaud. Patricia Renaud is a clinical psychologist who specializes in the assessment and treatment of neurodevelopmental and psychiatric disorders in children and adolescents. She also is the Associate Director of Can Reach, a training program that offers ASD-related workshops, educational lectures, and resources to community providers and families. Welcome.
Thank you so much for that introduction. It's really my pleasure to be here, and I'm excited to talk about one of my favorite topics. So I will go ahead and share my screen. There we go. Yes. So today I'm going to be talking about cognitive behavioral therapy for autistic individuals, and talking a little bit about anxiety as well. And so the learning objectives, kind of what the main areas that I'm going to focus on, and I'm also going to try and speak slowly because I know we are also translating into Spanish, but I'm going to be going over cognitive behavioral therapy principles. I'm going to be talking about common treatment targets of cognitive behavioral therapy in youth with autism. And then I'm also going to be talking about important modifications to traditional kind of models of cognitive behavioral therapy that are really important to use when working with autistic youth. So to start off, we know co-occurring mental health conditions and medical conditions are kind of the rule in autism. So these co-occurring conditions are very, very common, and it's pretty rare to see, a child with just autism spectrum disorder. Usually it kind of comes along with some of these other concerns. So these are some common ones. So we often see gastrointestinal issues. We see difficulties with diet. So a lot of times our kids have more restricted diets. They might have sensory sensitivities where that makes them only particular foods, eating a very limited number of foods. Or, it could be related to rigidity as well, and being, particular about keeping the foods that they eat the same, and only liking certain, brands of food, or liking foods that are consistent throughout time, like goldfish. It's always the same whenever you eat goldfish. We also see higher rates of epilepsy, so seizures. Sleep difficulties are also really common in autism, so difficulties falling asleep. staying asleep, and waking up early. We also see higher rates of oppositionality and defiance. Also higher rates of depression. So even in childhood, we see kids with autism who are also depressed. And oftentimes in childhood, that can look like increased irritability, and just kids who aren't as happy as much as we would expect them to be. And then that depression rates increase, especially in adolescence and in adulthood, much higher incidence of depression. We also see high rates of ADHD that co-occurs with autism. And so you guys will be hearing a lot about that a little bit later on today. And then what I'm going to be focusing on today is anxiety disorders. And so we do see much higher rates of co-occurring anxiety in children and youth and adults on the autism spectrum. And so there's been a lot of research on co-occurring anxiety and what the different rates are, what it looks like in autism. And one research study that kind of put all of those numbers, all of those smaller studies together, estimated that around 42% of children with autism are also diagnosed with some type of anxiety disorder. And so there's lots of different types of anxiety disorders. And when we talk about anxiety disorders, anxiety is a normal emotion that everybody experiences from time to time. So, anxiety in a lot of ways can be helpful, sometimes and adaptive. It keeps us safe. And it can motivate us, if we're feeling a little bit anxious about a test, to study. However, when we talk about anxiety disorders, that's when the anxiety is not helpful anymore. So it's highly distressing to a person, and it starts interfering in a person's life. So it's keeping them from doing things that they want to be doing. So for example, a child maybe is socially anxious, so it's keeping them from going on a play date at their friend's house, or they're really scared of separating from their parent, and so they don't want to go to school every day. So they're missing a lot of days of school. And so that's when, anxiety becomes a problem, and when we really want to think about how we can help. And so in terms of different types of anxiety, we really see all the different patterns of anxiety in autistic youth that we see in typically developing youth. But we see much higher rates than we see in typically developing youth. So we see higher rates of specific phobias. So that can be very specific fears of things like dogs or heights, or airplanes, things like that. So in about 30% of youth on the spectrum, they have a specific phobia. We also see higher rates of obsessive compulsive disorder, so OCD. So those are kids who have very distressing obsessions, and may also have ritualistic behavior that is also distressing to them. And so this, can be really hard to differentiate between some core autism symptoms, because we're thinking, oh, obsessions and also routines, that kind of sounds maybe like some autism characteristics. But the difference here is these obsessions are very distressing to our children. They're not things that they enjoy, like a fixated interest, for example. And then the routines as well. Kids are having to do them over and over again because they're worried if they don't, something bad is going to happen. And so we see increased rates of OCD. We also see, I'm sure not surprising to you guys, increased rates of social anxiety disorder. And so those are kids who are fearful in social situations, and they might worry about what other people are thinking about them. They're worried, that other kids might not want to be their friends, that they might do something that's embarrassing in front of other people. So that type of anxiety is really common in our autistic youth, especially as they enter into adolescence. We also see higher rates of generalized anxiety disorder. And so those are kids who just always seem to be worrying about things. They might worry about the future, about their family, about how well they're doing, about never being late, about doing things perfectly, about natural disasters. So just always seem to be worrying, and it's often accompanied by a lot of physiological symptoms too. So things like stomach aches, headaches, muscle aches, sleep disturbance. And like I was saying, these rates of anxiety disorders in kids on the spectrum are almost double the rates seen in typically developing children. And so there is also some research kind of on why that might be, and looking at, genetics, and looking at shared parts of the brain that might be implicated kind of in both. But also research looking at the daily experiences of autistic individuals and how increased daily stress also probably contributes to these higher rates of anxiety disorders. And so we know our kids and adolescents and adults on the spectrum experience high levels of stress from just having to interact and be out in the world. For example, dealing with sensory sensitivities. So, if we have a kid who, has to be in school all day with bright lights and they're sensitive to lights, that's going to be, much more stressful for them. And then that can contribute to kind of more negative mood and to increased risk for anxiety disorders. Or for kids, just having to deal with social interactions and interacting with their peers, and not knowing kind of what other people are thinking or what exactly they're supposed to do. That, could lead to higher levels of stress that they're experiencing, and then contribute to more anxiety in those situations. So there's also research looking on about that. And so now that we know kind of that anxiety is really common and all these different types, what can we do about it, right? And so cognitive behavioral therapy is the gold standard behavioral treatment for typically developing youth with anxiety disorders. And over the last 25 years, these kind of cognitive behavioral therapy techniques have been adapted for children and youth on the spectrum. And a lot of that work has been done here at UCLA with Dr. Jeff Wood, but also across the country. And so a lot of it is individual therapy, and also some different group therapy programs based on cognitive behavioral therapy that have been developed. Typically, cognitive behavioral therapy has been used in verbally fluent youth with average intellectual abilities, and that's because the therapy, it is a talk-based therapy, and so it is important, that the child is able to speak and converse with the therapist. However, it has also been adapted for more minimally verbal autistic individuals, and we can talk about that a little bit too later on. For cognitive behavioral therapy, it's appropriate generally for children 6 years old and older. And again, that's because we work on, there's that cognitive piece as well to it, where it works best with slightly older kids. And then it's different than kind of more comprehensive behavioral treatment such as ABA. Usually actually the child and the family meet with the therapist just once a week for about an hour, hour and a half, for about 16 to 32 weeks. So it's also time limited. So this isn't a therapy that goes on for years and years and years. So about 4 to 8 months, typically. It's also family-based. And so this is a little bit different than maybe kind of what people think of for therapy for maybe children and adolescents. But it's really important for the family to be involved in this type of therapy, especially for autistic children. And so part of the session is spent just with the child, but part of the session too is spent with the parents. And that really helps with generalization of skills. This type of therapy is also modular based, which means that each session is kind of like a different lesson that you go over, but the therapist can pick and choose which lesson kind of is appropriate and what they want to do with the child and what would be most helpful for the family. And that allows for a lot of flexibility with kind of these treatment manuals and individualization. And so there is a typical treatment sequence of phase 1. So that is typically psychoeducation. We'll talk a little bit more in depth about all these different phases in just a second. There's also skills training, phase 2, where we're teaching coping skills. And then there's phase 3, which is skills practice. And that's really how the majority of the sessions are spent. So kids are then practicing using the skills that they've learned through what we call exposures, but kind of practices or challenges. So in terms of what CBT or cognitive behavioral therapy has been shown to be helpful for, research has shown it helps reduce anxiety levels. It has also been shown to help with depressive symptoms, so to decrease depression, particularly through something called behavioral activation. Through these CBT research studies, we've also seen improvements in a child's social responsiveness and their social engagement with peers. So that's been some great research as well, where kids were actually observed on the playgrounds before and after these treatments, and were shown to be more engaged with their peers afterwards, after receiving the treatment. And then we've also seen increases in independent daily living skills. So that CBT can help with that. And this really great relationship where we actually see, as kids do more of these independent daily living skills on their own, their anxiety actually decreases. So they're feeling more confident in themselves and what they're doing. It can also work to increase flexibility and overall emotion regulation skills. So just an overview of cognitive behavioral therapy and the framework. So cognitive behavioral therapy is based on how our thoughts, feelings, and behavior are all related. And so how we feel affects how we act and think. How we think affects what we do and how we feel. And then our behavior, what we do, actually really affects what we think and our feelings. And so CBT works at all these different levels. And so an example of this might be, let's say, a child who is afraid of a dog. And so the emotion they're feeling is they're feeling scared, right? And so if they're feeling scared, that's going to impact their thinking about being around dogs. So they might think, oh, the dog is going to bite me. I'm going to have to go to the hospital. I'm going to get a really bad infection. And then that emotion and that thought is going to affect their behavior. You know, if they're thinking that they're going to get bit by a dog, what are they going to do? They're going to avoid dogs at all costs, right? And so that is very, very common response when we feel scared or anxious. We want to avoid, right? Because we want to keep ourselves safe. And so cognitive behavioral therapy would work kind of on all of these and working on these situations, because maybe that fear is keeping that child from going to their aunt's house because their aunt has a dog, or it's keeping them from going on play dates, or it's really a safety concern because every time the child sees a dog on the street, they run across the street immediately and have just this automatic response where, you know, they could get hit by a car and it's really dangerous. And so it can really impact a child. And so cognitive behavioral therapy would really help this child kind of identify how they're feeling about the situation. So letting, helping them know that they're feeling scared, what that feels like in their body. It would help kind of maybe I help them identify the thoughts that they're having. So those unhelpful thoughts of like the dog's going to bite me. And instead maybe think of like, well, have I ever been bitten by a dog before? What's the likelihood? It looks like a friendly dog. My aunt, doesn't have a dog that bites. She wouldn't, put me in that situation. And then it also works on changing a child's behavior then, where we gradually, through baby steps, and then where we work with the child, work with the family, and gradually get them more and more comfortable being around dogs. And one thing about this cycle is, with untreated anxiety, we sometimes call it a vicious cycle, right? Because if we're feeling scared about something, we think something bad is going to happen, we're going to avoid it, and then we stay safe. But actually, that just reinforces the whole circle. And so we actually become over time more and more scared of the situation. And so that's why it's important that through this program, we gradually start to face our fears, because that's what's going to reduce the anxiety. Just to go a little bit more into depth about the different phases. So we will work with children and parents at the beginning and really provide the psychoeducation around what is anxiety. So it's brain-based, it's activation of the amygdala, it's your fight or flight response. We'll also really work on helping kids identify when they're feeling nervous. This can be hard for adults. A lot of us, it's really hard to identify our feelings. So helping them identify those body cues like, oh, I'm having a stomach ache, or, oh, my hands are starting to shake, or I'm starting to sweat. These are signs that I'm feeling nervous. And we teach parents too. A big part of it is common patterns of child anxiety. And so again, it's kind of what I just explained, where it's, a child will enter a situation that makes them feel scared. They'll get really, really scared, really upset. And then usually what happens is they'll then be removed from the situation, right? Because it's really hard to see a child so upset. And so that's kind of a normal pattern, but like I just said, that actually kind of reinforces that situation is scary and unsafe to the child when they're just kind of removed from the situation. And so we'll talk about, through this program, children are going to be learning different coping responses, and then also just starting with baby steps that they're comfortable with to gradually start facing these feared situations. So that's part one. And we also, talk to kids, are teaching kids about anxiety. We will also incorporate teaching about autism to kids, who are aware of their diagnosis and what that means for them. And provide support around helping them understand their diagnosis, and also really in a strengths-based message about, these are some really good things about autism, things that, you can be really proud of and are wonderful. But, there are some other things that make that autism makes harder. And so that's what we're going to work on together here. Phase 2 is skills training. So this is where we teach kids and parents coping skills for ways to cope with anxiety. And so sometimes we will teach relaxation strategies or progressive muscle relaxation. But most of the time we'll work on helping a child identify the negative, or we call them icky, thoughts that they're having about a situation. And then help them instead kind of think of more helpful thoughts or calm thoughts. So we'll help a child identify kind of through thought bubbles, what are the negative things that they think are going to happen in this situation. So, for a child who maybe has generalized anxiety, they might be thinking, if I make or social anxiety, if I make a mistake, everybody's going to laugh at me and nobody's going to want to be my friend. That could be their icky thought. Or, if I fail this one test, I'm never going to get into college. That could be another icky thought that a child's having. or nobody's ever going to want to be my friend. I'm never going to fit in. No one, is never ever going to like me. Or for kids with separation anxiety, if my parents leave, they're going to get in a car accident and I'm never going to see them again. And so these are all common fears that kids will express and have. And so it's all kind of the bad things they think might happen. Then we help them identify calm thoughts instead. And so kind of thoughts that kind of fight back against those icky thoughts. So, thinking about like, oh, well, if I do make a mistake, how bad is it really going to be? If I'm giving a presentation in class, there's a good likelihood nobody's going to notice that I make a mistake. And also nobody's going to really care. Or another helpful thought can be, if something bad does happen, or could be, what's the likelihood of something bad happening? So it's not very likely that my parents would get in a car accident. They've never been in a car accident before. Or it's not very likely that I'm going to fly off the roller coaster. I don't know anyone that's ever flown off a roller coaster before. And then phase 3 is really kind of where the majority of sessions are spent in skills practice. And so that's where we will identify kind of key areas that we're going to work on and then break those down into baby steps. And so we'll have kids and we'll have parents rate these different situations from 0 to 10 for how difficult it is. And then we'll start having kids with their new coping skills gradually start facing these situations. So usually at situations that are around like a 2 or a 3 for them, right? Because we want them to be successful and for them to gain confidence in facing their fears. And facing fears is hard. And so we really give them a lot of credit for doing this. We never want to throw kids into, we say the deep end of the pool at first, we always start off, it's just like learning to swim. You start off kind of in the baby pool, then gradually on the steps and then go into the deeper part of the pool. And so that's just like how it is with facing our fears. And so children will practice in session facing their fears. And then, so it might be like for a child who's afraid to raise their hand in class, maybe they practice reading something in front of their therapist and reading something to their siblings or to their parents. And then gradually they're working up to participating more in class. Here we go, perfect example. So something we might do with, for a session with a child is, we always use lots of cartoons, have that visual. It's really helpful. And so this may, be a child. We'd be working with a child and we'd have them identify how they think this child is feeling based on kind of their facial expression. We'd have them identify some icky thoughts that they think this child is having. Then we'd help them generate some calm thoughts. And then we would try and brainstorm how we could break down this situation and problem solve so that this child could practice and feel more comfortable in this situation. Now I'm just going to talk a little bit more about some of the modifications that we use in cognitive behavioral therapy that can be really helpful for working with autistic youth. And so we do use a large-scale reward system. And this is, again, it's compensation for hard work, right? Like, a lot of adults have fears that they never face. And our kids are facing them, and it's hard work. So it's really important that they receive praise and that they receive, compensation, just like, we go to work and we're paid, similar. So we will brainstorm a rewards and privileges menu and for kids, things that they can earn throughout the treatment. And this makes therapy way more fun and really helps with motivation. And as you know, once a child faces their fears, that becomes reinforcing enough for them, and they don't need to continually have a reinforcer once they have taught their brain and learned these situations are actually safe. We also, like I was saying, use lots of visual aids. So that's really, really helpful to have something concrete and visual to look at and to explain these concepts. We will often also use special interests. So these could be in the examples that we're using. You know, Lightning McQueen was really nervous before his race. That can help increase engagement, or also in our reward system as well. We also can incorporate social communication goals. And so for, you know, maybe a child who's socially anxious, we might practice ahead of time what they might say, you know, if they're nervous about speaking to an adult. We, you know, might go over what are some rules for being a good play date host, to, you know, set a child up for success, for a child who, you know, maybe wants to have play dates and wants to have friends, but isn't, you know, is too nervous to do that, or too nervous to kind of invite a friend over. So we can incorporate these types of skills as well. We also will often incorporate independence and self-help skills. And again, we really see when those increase, when kids are doing more things independently on their own, like setting an alarm and waking up on their own, that can actually has a direct relationship with decreasing anxiety. We also have homework. And so this really helps with the generalization piece. So it's really not enough for a child to just come to therapy once a week to see gains. This is one of the most important ingredients. So they're practicing these skills at home every day and earning points for their practice. So that's another important piece. We also work a lot with the parents, right? And provide them with specialized parenting techniques to help them know what to do when they see their child feeling really anxious and in, you know, an anxiety provoking situation. So we really work with parents on modeling, staying calm themselves, right? That can be really hard when you're seeing your child very upset, but we really try and encourage parents to model staying calm. So staying calm, and if needed, to take a break themselves, you know, that can be really helpful and for a child to see. And it's going to make the child feel more calm when they see their parent being calm in a situation. We also encourage families to help children accept and label the emotion, you know, just by saying things like, oh, you seem really scared right now. And then just giving the child time instead of kind of rushing in and kind of removing your child from the situation or reassuring them right away and kind of doing that. We really help parents as children are building their own coping skills that we're teaching them to also allow parents to give their child time to then work through these emotions on their own, because we do know anxiety goes up, but you know, it always comes back down eventually. And so, you know, hopefully through therapy and these coping skills, the anxiety is going up less and less, and it's going down a lot faster. But it's important that children learn to kind of manage these feelings on their own. It can also be helpful to provide choices to a child who's getting stuck and anxious in a situation. So, you know, we're going to stay at this party a little bit longer, but do you want it to be for 5 minutes or 10 minutes? So just small choices can help a child feel much more in control, and then always rewarding. So I'm going to go ahead and wrap up my talk with just some resources for you all. There are some manuals that are out there. And so there's one, Managing Anxiety in People with Autism, which is a treatment guide for parents, teachers, and clinicians. There's also another manual for clinicians, the CBT for children and adolescents with high functioning autism spectrum disorders. And then also a book by Dr. Jeffrey Wood and Bryce McLeod, which is a family-based treatment manual. And that is for typically developing children, but what Dr. Jeff Wood's work that was modified for kids with autism is based off of, and provides a lot of helpful strategies for family-based CBT. And then the best resource is something that Dr. Wood has also created with his team at UCLA, which is Maya. It's a website where you can log in, and it provides you with an online CBT manual, lots of videos on how to do different sessions for therapists. and just all the resources that would be really helpful for providers who are working with autistic youth and delivering CBT for anxiety in kids with autism. And so that's available, the meya.ucla.edu public website. You do have to create a login, but then they'll give you access. And then just in terms of accessing CBT in the community, I wanted to make a note. So families can contact their insurance and ask for a list of providers who provide cognitive behavioral therapy and who also have experience working with children with anxiety and autism. So oftentimes we'll recommend families do that to find providers who are knowledgeable in this area. There's also some resources here in the community. Here at UCLA, we have a training clinic that provides CBT for autistic youth. There's also the CHLA Boone Fetter Autism Clinic that provides therapy and CBT. And then there's also these two other websites listed where they have provider databases to look to find a provider. So just some key takeaways, and then I think there's just a couple of minutes for some questions, but anxiety is very common in children and adolescents with autism. Cognitive behavioral therapy is really based on the idea that our thoughts, feelings, and behavior are all connected. And CBT can be used to reduce symptoms of anxiety. The three main phases of cognitive behavioral therapy are psychoeducation, skills training, and skill practice. And then there's lots of modifications that can be particularly helpful when working with autistic youth. So thank you so much for your attention, and looking forward to answering some questions.
Thank you, Dr. Renaud. Okay. So yeah, let's get into the questions, and there's a lot, and some of them are kind of related. So I think the audience really wanted to find out how to individualize CBT for specific cases. So what if they have limited cognitive capacity or communication skills, or because of their ASD, they may be hypersensitive to social situations like human voices and noises. So would you say that CBT is still the recommended approach, or are there other treatment options one might consider for these individuals?
Yeah, so really, really good questions. And there has been some kind of beginning stages of research on CBT for more minimally verbal individuals. Some things that have been tried to adapt CBT more for those individuals is more frequent sessions. And so kind of more greater repetition of these skills. So maybe meeting twice a week or 3 times a week. And also just simplifying the language that's being used. Using more visual aids, and also using some more like mantras and just repetition of, for example, maybe for a child who's scared of a dog, who has very limited language, they might think just have one thought that they really focus on and repeat to themselves when they're being exposed to dogs. There's also been research just on behavioral strategies in terms of treating phobias as well. And so I think those are kind of the main treatments that are available for more minimally verbal or cognitively impaired individuals with autism and anxiety.
Great. Next question is by Lillian. Is it suitable to provide face-to-face or virtual psychoeducation for individuals with ASD who consistently display aggressive behaviors or have difficulty controlling their anger or emotions? How do we determine if the individual is well suited for this type of therapy?
Yeah, really good question. I think we've definitely, gone back and forth between therapy that's provided in person versus telehealth. And there's benefits, to both. Obviously telehealth, virtual therapy increase access. Oftentimes it's hard to get into a provider's office. So that can be one benefit of virtual therapy. Also, yeah, if a child is very aggressive, that might be harder to see them in person in an office. Usually for this type of therapy, we're not too concerned about aggressiveness towards a therapist in session. And so they might have significant aggression towards family members at home. We often do see, and that's something that we can work on. But usually for this type of treatment, children are able to come into a therapy office and stay safe. But I will say, especially, it depends on the individual, if you decide if you're going to do telehealth or in person. Here at our clinic, we tend to, when it's possible, especially for children, see them in person, just because it can be a lot harder to engage via telehealth. And also if there's attentional difficulties, and also it's easier to build rapport and to do these exposures. However, we do see a lot of adolescents and adults via telehealth, and I think that can be really, really helpful and is probably just as beneficial.
Okay, thank you for that. And there are a few questions about accessing CBT. I know in the slide you did provide some resources, but would you kind of like reiterate how one might access CBT in the community?
Yeah. So we would recommend, if you have insurance, contacting your insurance and asking for a list of providers that have experience doing cognitive behavioral therapy and working with kids with autism and anxiety, and seeing what they come up with. And hopefully they'll have some providers for you. You could also, if you already have a therapist for your child, refer them to some of those other manuals or to that Maya website. To help, see if they'd be interested in learning more about working with autistic youth if they don't have as much of that experience. That can be, some parents will do that, and just providing resources, to maybe a therapist your child's seeing in the school, if that's where they're getting their therapy. There's also therapy available here at UCLA and also at CHLA, Boone Fetter Clinic. And so I think, those are some of the main ways to access.
Okay, thank you. In the interest of time, I think we should wrap up. We didn't get to all the questions. People are very interested in this topic. Dr. Renaud, if you have a few minutes before you leave, feel free to respond some of the questions in the Q&A. But thank you for this informative presentation.
All right, thank you.
So we're really excited today that we have teachers who've worked in the classroom with individuals with autism and really across the age span. So we're going to ask them some questions specifically about what teachers do and how they recognize anxiety in their kids. So we have Hillary Wu, who's here, and she was an elementary school teacher. She's now a graduate school student at UCLA. So she is working on her PhD. Then we have Elisa Schultz, who is she's now the director. Why am I stumbling? I've known her for 20 years. She is the director of the Spectrum program at New Road School, which is for neurodiverse 6th through 12th graders. And then we have Sonia Dixon, who was a teacher, special education teacher. She supervised programs in public schools, but is now the co-founder of Transitions and has a transition or a program called Evolve that transitions adolescents, young adults into the workforce. So we kind of have the age span here. And I think the ways in which we might recognize anxiety will be different across those age spans. So the first question is, how prevalent you think anxiety is in the lives of your students with autism? How do they demonstrate it? How do you recognize it? And so whoever wants to start that off, or we could start by age group. We could start with Hillary, maybe.
Sure, I can start. From my experience teaching with students with special needs and autism, I found that anxiety is part of the natural human experience, but because my students had that extra hurdle to get over, I felt like they all had some degree of anxiety. And ways I really recognized that was ultimately, the way everyone sees it first through their behaviors. So a lot of times they had quote unquote disruptive behaviors that would be reported to either me by their gen ed teacher, or I would see it in the classroom. So that was whether it was new or whether it was something I noticed the first day I met them. It kind of varied, but ultimately, one way I always made sure that I would be able to recognize it is just by establishing rapport and trust as soon as the year started. That would not only let them or let me get to know them better and understand them, who they were as a person, and what would upset them or what things they might need to access their environment, but also if things were different or seemed off, then that was automatically like a red flag for me. But also knowing all those things about them and what might set them off, I guess was a lack of a better word, I would be able to communicate that with a teacher. So and with regards to how they might demonstrate it, like I said, it's a lot of refusal to do work, which I think is really common for teachers to take into they see it and they think, oh, well, they're just trying to be difficult, but they don't recognize that that's just a manifestation of anxiety. So I think the refusal to do work is like a really overarching one that we see in the education setting. I'm sure my colleagues will speak to many more, so I won't go through all of them.
Great. What about you, Lisa? You've got those 6th graders through 12th graders.
I do. I have grades 6 through 12. And one of the great things about the Spectrum program is that we have these same students for 7 years. So we get to know them really well. So that relationship piece is key in understanding behaviors that might look and appear different. But I would say it is highly, highly prevalent with all of our students. I think anxiety is one of the main factors that our students struggle with on a day-to-day basis. In middle school in particularly, it shows up a bit different than in high school, obviously with the age group. A lot of stomach aches, headaches, moments that we provide for them a break, a safe place to come to, coming in and helping them in that first step is to recognize their anxiety. It's really key and important because a stomach ache, trying to determine, are you sick and you need to go home, or is this just anxiety? So we know our students so well that we can tell that. In the high school, we see a lot of repetitive questions, asking questions over and over again, seeking out that reassurance, and then 2 minutes later asking that question again. It can also lead to a lot of our students are very anxious about doing well in school. They want to be perfect. They want to do it right. And so they spend so much time doing and redoing and going over their work that it becomes to a point where they don't turn it in. It becomes refusal, but it's not an intentional refusal. And I think that's really important to understand, that they want to do well and this anxiety does get in the way. In both middle school and high school, we see students freeze up in the classroom. They might know the answer. They might be ready to participate. They've raised their hand and then all of a sudden the words don't come out. And the teachers know so well that the kids have a grasp and understanding, but they lose their momentum to really provide what they know in the classroom. So that brain freeze happens pretty frequently in both middle and high. And then I would also say, goodness. We see our students every day in the morning and the afternoon. So breaking it down for them, creating a plan is really helpful once they've recognized and taking those much needed breaks. And I know we'll talk about more about intervention in a moment, but it is really prevalent. We also see it in our neurotypical environment. So I just want to be really clear that it's higher and more pronounced with our students in the Spectrum program, but it's definitely, especially after the pandemic, very prevalent within our entire community.
Right. Right. And it continues, right? So the kiddos that start off in elementary school sometimes have unmet, solutions. continues. And so then Sonia, you get them and you're trying to get them into the workforce. And so what do you see? Similar kinds of things or different things?
Yeah, I definitely, it's lovely to hear from both of you that we're seeing sort of like the older version of what you're seeing, younger. So I'm getting individuals coming into our program, which is 11 months on, and they're 18 and above. And so either they've had intervention, so they're coming in with some level of strategy, or they haven't. We've been doing this for 6 years. I would say over 90% of the individuals that come into our program have a formal diagnosis, whether it's comorbid or a social anxiety or generalized anxiety. And then I would say that how we see it is a lot of overthinking, catastrophizing, avoidance, escape, isolation, and just a real fear of even imagining this idea of adulting and wanting so desperately to remain within the comfort of, I come home, I watch my videos, and this is where I stay, and this is what's comfortable to me. But I do know I want a job. And so there's a lot of, I would say there's a lot of challenges with reconciling. I'm now expected to, I finished high school or I finished college, and I'm now expected to go out there into the workforce. And what does that look like? And we recognize it through, just as you guys do, in behaviors that are, we recognize it in the same sort of behaviors. And I would say with the young adults, it's a resistance, a very clear resistance to take that next transitional leap, and a real fear, like a genuine fear. And I definitely would say I agree with both of you. Throughout my time in schools, it was always the behavior, right, that's pointed out. And it was, I don't know if you found this, I found it hard to get teachers and other people within the school system to understand the anxiety basis. And remember, I was in a public school system. So it's sort of getting them to understand, well, anxiety, they don't look anxious to me, or, I don't feel, well, why would they be anxious? I told them what we were doing in the class. And I really understood anxiety is probably very much under-recognized.
Mm-hmm. Well, and also with autism, it's probably hard to distinguish sometimes between, it's kind of natural sort of tendencies to really a anxiety disorder, like Dr. Reno talked about. So I'm thinking about those strategies that you use in the classroom. And I think you brought up something, Sonia, about and Elisa, about the sort of going into other classrooms, other places, and talking to other teachers and trying to get them to understand what the student needs. Perhaps one of the strategies is to help students advocate for themselves. And I imagine you all have very different strategies. Younger kids are different from older kids. So maybe, I don't know, Hillary, do you have specific strategies? And let's be mindful that I think a lot of times we're talking about these highly verbal, intellectually able, academically able students, but you can have anxiety even if you're minimally verbal and young. So if we can think, broadly.
Sure. One thing that I always used in my classroom was helping when I saw that there might be some underlying anxiety, just helping children learn about themselves and their anxiety by, like, if I'm mindful of, okay, they're trying to always be perfect and do their work perfect. So I'm thinking that might be worry, or that might be, fear. So I'm looking for videos either on YouTube or books, or pictures that might model that, and teach students about it and let them know that this is what it looks like. Now, this is how you might feel. And, again, a lot of visuals, a lot of videos, incorporating things they like, whether it be, I know Minecraft was a big one when I was teaching, and helping them recognize that and telling them what they can do next. So I know I've had students who were very preoccupied with being perfect and getting 100% on an assignment. So just helping them replace their thoughts or with what they were saying, whether it was, I always want to get this right, to something more positive. So, letting them know, like, I'm not going to get all this right, and that's okay because I'm learning, I'm at school. And I think something to keep in mind is that this is super repetitive and it's not going to go away within a week. It's going to take something that's very, very long term. So I would say within my setting, that was something that I saw very common, and I use a lot. So just like a lot of visuals and just getting to know the student and speaking with them.
Great. Elisa?
So we do a lot of professional development with our teachers, and we really inform our teachers about our students and who they are as individuals, because you meet one person on the spectrum, you meet one person on the spectrum, and what you might do for one student might not be what you do for all. So that individual approach is really important. And part of the professional development, we ask our teachers, if you're identifying anxiety, if you're seeing that one of our students, they're stuck, and you can use this with all students, is to take a moment, get down to their level, pause, ask them what they know, ask them leading questions. If that's raising their anxiety, switch topics. Talk to them about a preferred task. Get them to have a moment, a break within the academic classroom, and then go back to where they might be having challenges. So that's just within the teachers that we're asking them to do. But within the Spectrum program, we're asking them, take a break. It's a nice 5-minute walk to come and see us. Take that break. It's the mind-body connection. When we were in the pandemic and we were doing online instruction, we were teaching our teachers to do a 5-minute yoga pose, 3 poses, just to get that body and brain moving. It's just so important. One of the things that we were also doing with our students is, when we're recognizing anxiety, is practicing the self-advocacy to recognize it in your body, share with if it's your teacher or your spectrum teacher, or whoever that trusted adult is, what they're feeling and thinking, and then to remind them that, your feelings are not facts. And mistakes are part of life. We always talk about the skin the knee factor. We want our students to make mistakes because it's in making those mistakes that we find growth. And then I think reminding our educators that, if you're in a situation and you're highly anxious, your ability to take in information is cut off. So what we really want to do, which is way more important than teaching the topics at hand, is to make sure that everybody in the class feels comfortable so they can receive the information that they're taking in. So, these are just small best practices that are really helpful for all teachers. But our students tend to thrive in those moments of taking those breaks, having a breath, using mindfulness in your classroom. Have been super helpful. And then for those who are more sensory based, when they come back to the Spectrum program, we have a weighted blanket here if they would just want to take a minute with that. That's also okay. So it just really runs the gamut on who the individual is and how we can best support them.
Right. And we should say that the Spectrum program is a full inclusion program, but there's kind of a safe haven classroom that they can go to, which is what Elisa is referring to. Sonia.
Well, we were lucky because we got to design our curriculum, and so embedded in it, it's a career program. And one of the things we looked at was the statistics of why are individuals on the autism spectrum having a difficult time accessing competitive employment, and why are they not sustaining that employment? And most of the time it came down to the factors of anxiety and the tremendous limiting factors it has on your daily functioning, consistency in life. And so we developed our curriculum with emotional intelligence is weaved all through it. So it's really understanding who you are, how anxiety impacts you, teaching them about neurology, the brain, the fight or flight, working with them on healthy coping strategies, addressing their neurology. Mindfulness, we practice it every day. Box breathing, they have sleep hygiene habits. Physical activity, how does that help reduce stress? Healthy eating, which is challenging when your eating patterns have been established over time. And also being very, very accepting that you have anxiety, because so much of the time, the young adults walking into our program are trying to minimize it. They're trying to say, I'm okay, I got it. It's not such a big factor. And what we've sort of wanted to help our young adults understand is you have anxiety. And so it's about navigating life with it, not trying to work against it. We also are trying, as you said about working with your staff, we're trying to work with companies and helping them understand, because everybody has their diversity, equity, and inclusion department, which sounds lovely on the website. But when you actually dig deep, it's really confusing. What does that actually mean? And it means that if you have we're always talking to HR managers and the managers of the young adults who are being managed by these individuals. So much of the time they're like, wow, it's like light bulbs go off. Oh, that's anxiety? Oh, I didn't even think about that. Because really, if you don't experience anxiety to the level that the young adults that we're supporting do, it's extremely hard to understand. Because sometimes I'm like, even now, after all this experience, a young adult will say something to me and I'm like, really? You're anxious about that? And then I have to go, oh yeah, they are. So it's really, they are young adult. I think number one is the young adult getting to know who they are and being able to articulately, whether it's typing if they're minimally verbal, or if they're verbal expressing, being able to very clearly let people know what's going on so that people have an understanding and then adjustments are made. So that's really the core of what we do.
Mm-hmm.
Then we watch it sort of change. We watch massive shifts, massive. So it's,
yeah. So actually, one of the questions in the Q&A as well is sort of thinking about what kind of information can you give teachers or parents about their student and anxiety? And you've already touched on this a little bit, but maybe there's some other things very specific that you can help parents with or teachers and in that communication around anxiety and strategies. Whoever wants to start.
Well, I can start with the young adults, because by the time the young adults have come into our program, the whole family has been impacted by this anxiety, this young adult. And so there's been a lot of adjusting to it, ways to avoid it, ways to make it not happen. And so what we've talked a lot to our young adults about, because we don't work with families or really have much to do with parents, but the young adults go home and sit down and really explain to their parents, this is what anxiety, this is how it affects me. And when you do A, B, C, D, it actually triggers it or makes it more impactful. Can we talk about interventions and supports that you can provide me now as I'm learning these new strategies in healthy ways to cope with my anxiety? So we really work with, it still goes back for our young adults, it's advocacy. They have to be able to explain why, what, and how, so that their parents and the people around them, because the parents have often just tried to cope, and that's really challenging. How do I support this young adult, but the anxiety is all encompassing and it's become part of the family dynamic. So that's how we address it, because it's going to be a useful skill when they go into jobs, because they're going to have to explain it to bosses and co-workers too. So
yeah, part of
it
it
address it.
Part of it sounds like it's just being really fearful about situations. And so obviously we become less fearful if we have experiences.
Yeah.
And so we have to create those. I'm thinking back to Patty Reno's talk about the exposure. So in thinking about that, and I know in your program, Sonia, you guys do a lot of exposures. I would imagine with our other age groups, the same thing. If you want to comment on that, or if that's a helpful solution.
I can absolutely comment on that for sure. So part of my role is to help our seniors move on to college. And there's a lot of fear and thoughts about college. But for our students on the spectrum, it's at a very heightened level. And the process of writing their college essay is often writing about their experiences. I had one young lady write about the monster that is anxiety. And her whole essay was about how she overcame the monster and recognized who the monster was and how to keep the monster at bay. It was brilliant. It was absolutely brilliant. And I feel that working through these opportunities in life is really helpful for our students. But one of the things we specifically do is we do a lot of role play. We role play it like you're going into your first college class and you're meeting your professor for the first time. What do you need to say about yourself, who you are, and what you need? And so we'll role play that. We'll role play that also in a setting where maybe it's here at New Roads and you're a mentor or you're helping out with part of our productions. You know, how do you share with adults and peers? And how is that language different? Because we talk one way with, you know, our future employers or college professors, we talk differently with peers, we talk differently with family, right? So recognizing that, coming up with your pitch of who you are and what you need is really important. And then for our younger students, I would say to parents, when you're at home and you're talking, stay calm. It is so important that you don't match their level of anxiety. It's so easy to fall into that trap. And teachers too. It's so easy to fall there, but just to remain calm, to reassure. And then if you can make a plan, something physical and tangible that you can take in small chunks that they could actually execute, it's incredibly helpful to go from a high situation and then to manage these small chunks. And at the end of it, say, see, here were your fears, and look where you are now. You did it. You found success, because that's providing confidence. And that confidence is going to allow them to say, wait, nope, this is the anxiety monster, not me. And that can really help them, you know, move forward. So it is something that has to happen and be generalized between home and school and then their next setting and their next setting. It's not just, you know, something that's going to happen at school or something that's going to be happening at home. It's a full-time opportunity to work on yourself. And that's also hard. So being reassuring, I think is also super key.
Well, I'm thinking, Hillary, you talked about visuals, and I know that in the schools, and Sonia loves visuals.
I love visuals.
And so having that thermometer of emotions and recognizing those emotions, was that useful? Is that useful for helping with anxiety and recognizing that anxiety it's an emotion? I mean, it's emotionally laden. Do you use those or other strategies, perhaps?
Yes, at my school site, we use a lot of those thermometers or zones of regulation, I think is like the fancy long term for it, but they're essentially all, I don't want to say they're all the same because that might not be true, but they all have some degree of colors associated with a visual word or a picture. And I really liked those because it involved all stakeholders. So it wasn't just for the student, but it was for the teacher as well, because when the teacher learned to associate the student and their different varying attitudes throughout the day, they would know how much they needed to step in. So if the student was not be able to advocate for themselves, whether it be like they couldn't tell the teacher, I need to step outside, they weren't at that, they were too in the red zone, I guess, or too upset to say that, then the teacher knew they had to step in and say, hey, it looks like you need a break, you can go outside, or whatever that student may need in that moment. So it was helpful for the student to learn about themselves and be able to raise their hand or approach the teacher, but it was also helpful so the teacher knew when they had to step in.
Great. There's a question. We have just like 3 minutes left, but I've been monitoring the questions, so they've been getting answered. But here's one where they want to have tips for educators in higher ed, that would be me, to work with individuals exhibiting autism symptoms like anxiety in college or even in graduate school. And are the tips similar to what you guys have already provided? And I think that they are. I have a graduate student, I don't know if she's listening in, but she told me that she's really anxious and she's just learned to talk to the anxiety. So she talks to her anxiety and calms herself down. So I think that we do see a lot of anxiety in the amongst just college kids in general. I think it gets amplified when the student has something like autism or some other condition in which they're really a little more worried about how they present and so on. And so I think some of the the strategies are very similar, but maybe you guys have something more to offer because you also send your students or your clients off to college or work.
I think for our young adults, especially when they're going into work, it's them developing a really good toolbox of strategies that work for them, whatever it is. And I do believe in personalizing, because there are obviously general strategies, mindfulness, yoga, sleep, etc. But I love the one about the monster and because to me, you have to sort of make friends in a way with your anxiety and understand it. And then it's about what works for you. So for our young adults, it's really making sure that they are working really hard on identifying triggers, identifying patterns of anxiety, and really figuring out what strategies work for them and what don't. Because sometimes what happens is they're also feeling anxious about the fact that the strategy that we said would work doesn't. And then they're like, well, I'm anxious because you told me this would work. And we want to, with our young adults, really reassure them that everybody's different and what works for one person may not work for another one. So it's them personalizing their strategies too.
Yeah,
no, that's big, for us.
All right, we are almost out of time, and next we're going to actually listen to a presentation on ADHD, another common condition that's co-occurring with autism. And then later we'll hear from our self-advocates or our autistic individuals that are in this Evolve program, and they're going to have lots to talk about in terms of anxiety, I'm sure. Really, thank you all for participating. This has been great.
Thank you.
Thank you.
Thank you. So our next presenter that we are welcoming is Dr. Elizabeth Dorman. She is a child, adolescent, and general psychiatrist practicing in Los Angeles. Dr. Dorman currently works with youth and families with ASD, intellectual disability, and other developmental differences through the West Side Regional Center, Spectrum Psych LA, and the Los Angeles County Department of Mental Health. She is on faculty at both UCLA and Charles Drew University. Welcome, Dr. Dorman.
Thank you. It's so wonderful to be with you all. I'm really, really delighted to be here to talk about this confluence of autism spectrum disorders and ADHD and how we can work together to address some of the symptoms. So I'm going to share my screen now. And move into right away into talking about what the aims of this discussion are going to be. There's so many things to discuss, but what we're going to try to get through is to talk about some of the core features of ASD, which you already know and we'll review, and the core features of ADHD, and the way that those symptoms can overlap. And then I want to spend a little bit of time talking about the trajectory of ADHD symptoms over the lifespan, so we can think about that in relation to the individuals we're serving, our loved ones who are experiencing these symptoms. And then we'll spend a good chunk of time talking about treatment strategies. And throughout, something I really want to encourage and want to empower is this idea of feeling confident in navigating some of the core hallmarks, the core symptoms, and discussing that with clinicians you trust when you're interested in getting a diagnosis or working towards treatment options. Because particularly for those folks who are with us today, who are parents, who are caregivers, you are the greatest experts on your children, on the youth that you're caring for. And so everything that you bring to the table in getting collaboration with professionals is going to be so important. So we'll review this. Of course, you're here, you know a lot of these things, but when we're thinking about autism spectrum disorders, we're thinking specifically what makes it unique is this challenge in social communication. So that difficulty with the reciprocity, the changes, the differences in the use of gestures, in the way speech is used, and even the range of affect. And trouble understanding social cues. And this can translate, and we see this a lot with the youth and young adults that we're working with, and difficulties with forming close friend groups and feeling connected. And finding our way, because our society is built so much on those type of social connections. And of course, The additional components that we look for and that we end up seeing in people with autism as well are some of these restrictive or repetitive patterns, and they can be patterns of behavior, of thought. It can manifest in some things that go more on the spectrum of anxiety, that can go on more on the spectrum of obsessional symptoms, but also just certain interests that are of high intensity, and ways in which they actually can demonstrate a perspective that's very unique and important for the world to hear, but can cause some challenges too. There are also some changes in body movements, in terms of things that make them feel more comfortable, and sensory differences. And a big hallmark is some of the challenges with shifting routines. And we all know that can be especially challenging. For ASD, the diagnostic process, as you all are aware, can happen early on, especially for those children who also have more developmental delays in other areas or meet the criteria for intellectual disability. And so for those children, they're often identified earlier, and they may be identified through their pediatricians. But for other children or young adults and even older adults, and I see the full range, they may not receive a diagnosis until much later because of the ability to mask or compensate in other ways to get through school, to get through life. And so we are seeing people at all stages. One thing that is the gold standard in terms of autism diagnosis, of course, is a socially interactive assessment. And having history from the caregivers. And usually, the tools we love to be able to use are the ADOS and ADI, but those are not always possible. And so we use the tools that we have to make sure that we can get people diagnosed and get them access to care. So let's think a little bit about ADHD symptoms. Now, I know this is a busy slide, there's a lot going on, but I want to focus on the top here, what we call the tip of the ADHD iceberg. So like Dr. Renaud had described with ASD, so with autism, we have a lot of co-occurring challenges that can happen medically and in terms of mental health, such as anxiety, like we discussed. With ADHD, we have the primary features, but then we also have so many co-occurring things too. So let's talk about the primary features. The three hallmarks are inattention. Another term for that is executive dysfunction. And that basically is referring to the prefrontal cortex. It's a part of our brain that does the most high-level tasks for us, and we'll come back to that. But those tasks involve being able to stay focused when someone is talking to us, being able to listen, to problem solve, to take the time to do things, to remember where we put things, where we keep things, and to follow through, to start thinking about something and then continue thinking about it enough to get the task done. That is a core challenge for people with ADHD, and we'll talk a little bit more about that. There are two other areas that are impacted with ADHD. One is hyperactivity, and the other is impulsivity. Now, a person may have all three of these areas very impacted, or may veer more towards one or another. But we tend to see, and we'll talk about this in just a moment, that people who have hyperactivity and impulsivity symptoms tend to be diagnosed earlier than people who might mainly have the inattentive symptoms. For the hyperactivity, that's the situation where you get a call from school because your child is not able to sit down during circle time or is moving about the classroom and being labeled as disruptive. Impulsive symptoms can sometimes look like, oh, your child is blurting out answers in school. They're having trouble not talking or not taking turns. They might be viewed by other children who they're engaging with as being intrusive, as sort of socially not getting along as well with people, not because they don't understand the social undertones like someone with autism, but because that they have more difficulties with being able to control their impulse to engage. And so for people who have both autism and ADHD, we may have both of those symptoms. Now, when we talk about these things that are underlying it, I want to just bring attention to this because these are things that people experience really commonly, and that sometimes can lead to either the diagnosis being missed or they're things that might not be adequately acknowledged or treated. And one of those that I want to point out here is this low frustration tolerance. So something that we see really commonly for children with ADHD is that they might have more reactivity. They might respond to things very quickly. They might not respond to structure and the typical type of discipline as in the way that other children do. And sometimes they may be labeled then as oppositional or as defiant. And something that I sometimes see is that children will be given those labels, but the underlying ADHD is not acknowledged. Those labels are also given disproportionately. So there's more bias for minoritized children in giving these labels related to these underlying symptoms of low frustration tolerance without really recognizing what is actually driving some of this. And some of what might be driving it, and there are many things, but some of that may be ADHD. So I want to call attention to that as well. ADHD is often diagnosed by pediatricians, but it's often missed also because they have a lot of things they're looking at. It is a clinical diagnosis, and that means that you don't have to do specific testing. It's more based on the report, but it needs to be in two settings. So it needs to be a report from experiences at home and experiences in school or another setting. And for many cases, it actually can be quite helpful to have additional testing, often through an IEP process or through separate types of testings if that's something that you can access, but it's not necessary. So let's talk about this combination, because there was a time not so long ago, we go back to 2013, which to me was not so long ago, but I guess really is, when there was a different attitude and understanding of ADHD and autism. The thought was at that time that if you had a diagnosis of autism, you couldn't also have a diagnosis of ADHD because autism sort of covered all the bases, right? And it's only since 2013, and that is when what is called the Diagnostic and Statistical Manual, which is the manual of mental health diagnoses, that was updated to reflect the fact that actually the reality is that we are seeing an enormous confluence. So up to 85% of youth who have an autism diagnosis also meet criteria for ADHD in terms of these inattentive, hyperactive, or impulsive symptoms. So it's exceptionally common. It's more the rule rather than the exception. And together, these children constitute about a quarter of children who are receiving services through the schools. And that really is an underestimate as well, in terms of, like I was saying before, there are a number of children who fly under the radar or might be labeled differently, who actually really should be receiving services for these things. There is some combination of genetic predisposition that seems to align between the two diagnoses. That being said, ADHD has a higher level of heritability, up to 75% of ADHD diagnoses can be traced within families, and both confer some social challenges. We talked about that just a moment ago in terms of with ASD, it really is going to be that fundamental difference in understanding social engagement and in being able to communicate in a socially nuanced way. For ADHD, there's more understanding. If a person just has ADHD, there's more understanding of the social nuance, but because of the impulsivity, it may be hard to make and keep friends, especially for young kids, because they are seen as being more intrusive or having too high of an activity level for the other kids to feel comfortable with. And when you have both, you're dealing with both social challenges. And so that's something that we often are teasing apart because they are still distinct from each other. Now, part of that distinctness is in what the symptom trajectory looks like for ADHD. So for autism, we know these core symptoms, they manifest early. They're both autism and ADHD are developmental disorders, meaning we see them early in life. And in autism, we can see some really dramatic improvement for some children and some chronicity and continuation for others. And most people end up experiencing a pretty similar level of symptoms and challenges that vary according to life stage. With ADHD, we see a few differences. At the beginning, so right here in this graph, you see this time is preschool. That is when those children who have some symptoms of hyperactivity and impulsivity, they're going to be picked up usually. And so they're the ones who are getting the earlier diagnosis, because when those symptoms are present, they can really be quite apparent and they can affect the learning environment. But they also improve over time naturally. And so what we see is as kids grow older, hyperactivity in particular decreases. And that's the natural course. It becomes more manageable. There might still be some restlessness. We see that a lot in adults, but the degree of hyperactivity really changes. The same is true for impulsivity to a lesser degree, but it improves over time, and we can expect that. What seems to stay really the same, so it's more similar to the autism spectrum disorder trajectory, are the inattentive symptoms. And those are the challenges with weeding out distractions, with being able to follow through on tasks, being able to remember things. And so that is often the persistent challenge that we are looking to treat and support over the lifespan. Another thing I'll mention here before we move on is that something that commonly occurs is that females tend to, in both autism and ADHD, tend to be underdiagnosed. And there are a lot of reasons for that, which we won't get all into right now. But one thing to consider and think about is how for a lot of females, they end up having a little bit of a lower level of hyperactivity and impulsivity during those early years as a group. And so they're picked up a little later because they seem to have more of the inattentive profile rather than some of these other symptoms. That's not universally the case, but it is something to think about. So for your children who are female, your daughters, it's something to consider and keep a close eye on because it may not be picked up in quite the same way. Now, when we're thinking about how we're going to start supporting youth who have ADHD and who also have autism, we're really thinking about what can we do at home, what can we do at school, and then what can we do medically, and really considering the whole child and knowing that we've maximized our resources before we've added medications. So when we're thinking about things that we can do at home, one of the things that can be most helpful is looking into training. And these can be the primary type of training that can really help as a parent and as a caregiver is thinking about behavioral management. And it's sort of a formal word for just structuring those rewards, positive reinforcement. How do I find a way to really pay attention to the things that I really like that my child is doing and to get more of those, and pay less attention to or have very appropriate consequences for the things that I don't like so much or that are getting in the way. Another thing, and we'll talk a little bit more about that, another thing that is very helpful across both ASD and ADHD is ABA. And that is because that the one-on-one contact and the structured sessions are very, very effective in being able to build structure and salience to things to getting tasks done that are the most important. For patients who and families who have Medi-Cal, there are some other services available as well, such as therapeutic behavioral services, TBS. And if we get to a certain level of challenge within the child's behavior, that's something that we can access. And as we talked about social skills training, there are these social aspects for both that are specific to both ASD and ADHD. And so some of those aspects can really be addressed through social skills training, and there are different things that will be addressed at different times over the course of the child's development. And then the organizational skill component, sometimes you might want to bring OT, occupational therapy, into that, can really, really help for that particular child to have a sense of how to structure themselves so they can get through what they need to get through. At school, something that is so important is when you're suspecting that your child has ASD, ADHD, or the combination of both, is really for the school to be providing some level of support and services. And schools, especially our public school system, because they are so overwhelmed with needs and requests, it can be challenging. And I do end up seeing a lot of children who technically are eligible for those services who may not be getting them and may have some labels that are, like we were talking about before, that really aren't addressing the root of the issue. And so in these situations, I really recommend requesting either an IEP or 504 assessment. Generally, I recommend requesting that IEP evaluation so that you can really not only determine, help support the school in determining what is going to be most useful, but also identify any other academic difficulties or learning differences that might be happening, and then implementing those accommodations and supports. Some other strategies to use at home that can be very, very helpful include a number of these things, which we won't go into a lot of detail about right now for time reasons, but having your own sense of organization, of reducing distractions. Maybe that means there's no phone or no TV during certain times, and of being really clear and specific and limiting choices, because that helps to structure and contain the environment. Breaking down tasks is really important. A common thing, an easy thing would be, instead of giving a request that has 3 different steps, give 1 step at a time to make sure that your child is able to execute and follow through on each of those steps. And then finding a reward system that really feels good for you so that you can feel like you're disciplining effectively and in a way that is not setting you or your child back. Because you ultimately really want to be developing and continuing this really positive relationship where they feel good about themselves, they feel success, and that they are achieving things. A common thing with children with ASD and ADHD is often not, even though they may be extremely bright, really not always being able to demonstrate or complete work in a way that demonstrates their skills. And then for children who are at different levels of functioning, there's the same degree of importance with really having that positivity, limiting and narrowing the environment so that most of your interactions are more positive rather than negative. So when we're thinking about how we're going to be addressing some of these target symptoms, this is a schematic that I think is useful for just considering when you're seeing a child psychiatrist, what are some of the things that they're thinking about? And there are a few things I might change here, but I think they indicate some things really well. Right here, in the blue, we have the core ASD areas of challenge, and that's what we talked about with the social communication deficits and the repetitive behaviors. Now, those are things that we don't have medications for. We have some very effective therapies, and we also know that for a lot of people, those things stay consistent over the lifespan. Now, the things in gray, we do have medications for and other treatments for. So one of the things that we're doing when you're seeing a professional and you're starting to talk about how are we going to target some of these challenges is that person is going to be thinking about, okay, what are our priorities here? Is sleep the main problem? Are we dealing with really high levels of depression and anxiety that we actually need to manage first? Is ADHD also leading to some aggression, some self-injurious behavior? And of course here, for children with intellectual disability, have we focused on making sure they can communicate as effectively as possible? Because that is often a root challenge for some of the behaviors that can be harmful to themselves or can cause a lot of distress. So first, we're going to prioritize. What are we focusing on, and how are we going to tackle one piece at a time? Once we determine that we're focusing on ADHD, because maybe it's having some effect on aggression and self-injury, maybe it's having some effect on worsening and anxiety symptoms, and it's causing a lot of challenges in school or with accessing therapy, then we're going to start thinking about how we're going to treat it. And I realize I might be running a little bit low on time, so please let me know. I'm going to try to move through this quickly. So when we're focusing then on ADHD, we're looking at treating, when you're starting to talk about medications, we're looking at treating this area that is highlighted in blue, and that's the prefrontal cortex. And it has a lot of different neurotransmitters that are all these little letters around this image that affect this area of the brain. And there are two that we focus on when we're using medications. One is dopamine, and the other is norepinephrine. So what we're trying to do is basically help, when you're looking at this scale, you're seeing it's like a dimmer switch. Here on the very left side, when we don't have a lot of those neurotransmitters in certain areas, we're essentially going to not be able to function at all. And we're in a state of being asleep. But as we have more of those neurotransmitters come online, we're able to pay more attention. The best place to be is to be in the middle, because if we have too much activity in that area, we actually can get very overwhelmed. And that happens, and for a lot of families, when there have been situations that are very stressful, very overwhelming, and traumatic, we can often be hyper alert, or it can even move into areas that are more distressing during those periods of hyperactivity. So we really want to move into this middle area where we have just enough of the dopamine and norepinephrine firing, but not too much and not too little. And this is overwhelming, but when you get the slides, my hope is that you can look through these and just have an idea of what's available to you and what your doctor is thinking about when you're consulting about medications for treating ADHD. These are the methylphenidate stimulants, and these next ones are the amphetamine stimulants. And they are the medications that in all of psychiatry, we find work the most effectively. There are a number of cases in which you may choose to try one of these medicines, or you may choose to try something different, which we'll talk about. But these are definitely something we think about and we consider, especially the long-acting formulations, because of the way they help the dopamine and the norepinephrine find that middle area of activity, so that throughout the day, children can learn more and hopefully be able to engage in their therapies better, and challenges in behavior can decrease. Now, one challenge with these medications is that there's a widespread shortage, and this has been true for over 18 months. So it's been true for quite a long time. And it's something that continues to be a significant issue. And so you might find that some of these are not available, or that you have to switch from one medication to another. And for that reason, and for other reasons, including side effects and just preference, people may choose to do something a little bit different. For instance, using non-stimulant medications. And the first two here are very similar in Tuniv and Capve, and that they are long-acting and they work on norepinephrine. And they can help with some anxiety, and they can also help with mood, and they can help with tics as well. So there are a number of things that we might be targeting and using them for. And sometimes we use them in combination with stimulants. The other things here, the Strattera and Qelbree, are medications that also work over a long period of time for norepinephrine and can make a difference for a lot of kids in reducing some anxiety and improving ADHD symptoms. And I'll say just really briefly about supplements that there is some evidence, especially for omega-3 polyunsaturated fatty acids. And these are things you might buy at the pharmacy without a prescription. The challenge with giving recommendations about using supplements is that we don't have an extensive amount of data from this, because we haven't been able to study this formally in this country because of the way things are organized within our government. And so we aren't able to tell to tell patients a lot of detailed information because we don't have a lot of detailed information. So my suggestion generally is, if you are considering using supplements, to first make sure that you've optimized and considered all the treatments that have a lot of evidence behind them. And then find a doctor that you trust to make sure to get some baseline labs and to talk about how you would select a product and how you would dose it. And the last thing I want to mention here is some additional treatment options that are available now. This is actually a new FDA-approved treatment for ADHD that has some data that it actually works as well as some of these medicines, but it is something that works on this nerve that is in our faces, that goes through our forehead and through the entirety of the face. And by activating that nerve through a sticky tape that then activates signaling, we find that for a lot of people, they can actually experience improvement and symptoms. And this is approved at this point from ages 7 through 12. And there are some ways to have access to using this particular treatment. And again, it's something that is promising and has data and has been approved. It's not fully accessible to everyone yet, but it's something that we can all consider. So I know that was a lot of information, but I appreciate so much being here and being able to talk with you about some of these many different aspects of treating ASD and ADHD.
Thank you, Dr. Dorman. That was very informative, wonderful presentation. We have some questions in the Q&A. First, Denise posted a question that's relatable to many of us. So for those with or without ADHD, do you think that screen time and social media negatively impact our attention skills?
That is such a good question. And there is data to suggest that it does. However, we don't have conclusive data on that. I think any of us anecdotally can say that we notice that it certainly doesn't seem to help. And the more things that we have available in our environment that can take us away from the task at hand, the more challenges we're going to have. So generally, I am definitely a proponent of considering screen time limitations and times when you have access to the phone, TV, whatever it might be, and times when you don't. Especially if you or your child, I think it's helpful for all of us, are having more challenges putting it away to be able to focus on something else. So it's a good practice to have. And I think our society is filled with more and more distractions. And so it becomes harder and harder, and that is hard for our brains to manage. So anything we can do to make our environment more simple is a good thing.
Thank you. Our next question, I'm going to combine two similar questions here. With those DMH Medi-Cal services, can you speak a little about the different types of services available? So you mentioned the therapeutic behavioral services, and this person mentions FSP, FCCS, REP, etc. And how do you get connected with these?
Yes, so those are really great questions. There are a whole range of services that are available, just like you mentioned. One of the things that is important is there are different eligibility criteria for each of these services. The first step is going to, if you are Medi-Cal covered, going into a DMH clinic, either a child clinic or adult clinic, whatever is locally assigned to you. So it's based on where you live. The next step would be during the assessment, based on the history that your child has had in terms of any involvement with foster care, any involvement with DCFS, which is the Department of Child and Family Services, any psychiatric hospitalizations, or any psychiatric holds, meaning when they've needed to go to the psychiatric ER. Those will all be taken into consideration to determine which programs you may be eligible for. Some things like wraparound services are only eligible if there is association with the Department of Child and Family Services. Others, like FSP, are available to anyone, just based on the severity and the need. For behavioral difficulties that tend to be more ADHD related, TBS tends to often be the best fit because it's targeted for younger children who might be having some difficulties at school or at home with behaviors that are harder to manage. And it gives more support in developing strategies as the parent or caregiver for how to manage those challenges.
Thank you. And there was some interest about the ETNS treatment that you mentioned. Somebody's asking about the actual name of that treatment. They missed it in the slide. And
Yes.
another asked, how does one access it?
Yes, and I apologize because I went so fast through those last parts. So yes, so ETMS, the company that is making it right now and producing it is called NeuroSigma, and they're based in Los Angeles. And so it's essentially, it's stimulation of the trigeminal nerve. And by contacting them directly, you can, and ideally, first, you do a few things. One is you have a physician that you trust. Usually that would be a child psychiatrist for making this prescription, but there may be some pediatricians who are comfortable with this. And you'd go to the website, you'd bring them in the information about this particular treatment so that they can read the data. And then they would send a prescription to NeuroSigma, and they would work out how to make sure that you're covered by a waiver program so that the cost is much lower. And then you'd get the cost estimate. So that is how you can access it.
I see. What do you recommend for a kid that cannot take medication?
Yes, so for children who can't take medication for various reasons, definitely the behavioral, all of these behavioral interventions in terms of structure at home and at school, and having those two places be as consistent as possible is the priority. Another thing to consider is when we think about medicines, I think for all of us, it brings up a lot of different feelings, a lot of different thoughts, a lot of different experiences that we've had. And for children with ADHD, something that I'm often thinking about is how a lot of these symptoms, even with all the behavioral treatments, we're not going to see a full resolution. And the medications are effective enough in ADHD that it's really worth thinking about if there's any category that you'd feel comfortable with. And it might not be one category of medicine, but it might be another. So I usually find that if we've maximized everything we can do behaviorally and we're still having trouble, it's worth looking at each of these categories of other treatments very carefully together to determine, could one of them be something that would be reasonable? Because we do know with only behavioral treatments, ADHD tends to not be fully responsive, but it's still worth doing everything we can at home and at school.
Mm-hmm. How about diet? Somebody's asking about the relationship between diet and ADHD symptoms or ASD symptoms, such as gluten-free diet.
Yeah, there was a period too where, and there are always new things, so I may be out of date too with the newest diets that are talked about right now, but there's certainly there have been a lot of discussions of different diets, different supplementations, and we don't have data to support that for every child. However, there's definitely cases where individuals are sensitive and to whether that be to gluten or to other dietary items. It might be dairy, it might be a number of different things. And in that case, it's worth making some changes. The key things that I think about, number one, is there a significant medical issue? For instance, there are such things as severe gluten allergies that's called celiac disease, and that is a very serious medical problem that needs to be treated by a GI specialist. If it's a sensitivity, that's a little bit different. So first, we need to rule out anything serious. Then the second thing that we need to do is make sure that the child is still getting all the vitamins and minerals that they need to be getting in their diet, so that we're not restricting their diet to where they're not getting enough of the basic components that their body needs. And then the third thing is, once you have those two things taken care of, you can experiment and see, do I notice an improvement with making some of these small changes? But I would definitely talk to your pediatrician about that before making some changes, just to make sure that you're hitting all the necessary nutrients first. But everyone is different and can respond to some of those dietary changes. There's not one formula for everyone.
Okay, I think we have time for one more question. Can overactive ADHD cause psychosis? Is there any relationship?
It's and that's a great question, especially because of this slide, which shows how on this, when we have overactivity in the prefrontal cortex with certain neurotransmitters, it can look like psychosis in the most severe state. Overactive ADHD unto itself, though, it does not move into psychosis. And that's something that is important to distinguish, and definitely really an important aspect of clarity. That being said, people with autism do have a higher risk of developing some of the psychotic disorders. And so we want to always keep an eye out for that. There's a complex discussion here about how psychosis happens in terms of dopamine and when there is too much. And that can be when it can happen organically in the brain, and it can happen when people are consuming certain substances. Even some of the medications that we use for ADHD, if they were given in great excess, then people might experience psychotic symptoms from that. But ADHD unto itself does not develop into psychosis. It's a separate process.
Okay, thank you, Dr. Dorman, for educating us on ADHD and ASD and treatments.
Thank you all so much.
So let's welcome Robin Shipley. She is the co-founder of Transitions Consulting, offering innovative, valuable, and goal-oriented services for neurodiverse youth, teens, and young adults. Transitions also offers private individual sessions for young adults who are interested in developing a goal-oriented life plan and developing skills needed for a successful transition into adulthood and employment. Welcome, Ms. Shipley.
Wonderful. Thank you so much, Liz. Hello, everybody. I'm very excited to introduce our panel. Yes, we have an amazing program called Evolve into the Workplace, which focuses on soft skills development to help our young adults who we have the pleasure of working with meet their employment goals. They learn transferable skills that help them in any job. Sonia Dixon and I are the co-founders of Transitions. You got to hear from Sonia earlier. So now with great pleasure, I'd love to introduce our panelists. And then Ivan, you'll probably want to change your name just so it reflects you. So I'd love to introduce Delvin. If you can just give a wave so they can see you. There's
Hello.
Delvin. Anna. Her
Hello.
lovely flower background. And there's Ivan right there. Okay,
Hello.
beautiful. And then Mackenzie.
Hi.
Is over there. Excellent. So our panelists have been so wonderful about really being open about how anxiety impacts their daily lives, whether it's in their internships, jobs, or just in their daily living. And we wanted to ask them questions to be able to help, them really express their thoughts and feelings, because I know you've heard so much from providers, so it's great to have that first person perspective. So we have 7 questions, and then we will absolutely leave time for your questions. And Sonia, you're going to be so kind to check the chat for those questions and to think which would be the best ones for everyone to answer.
100%. I will monitor the chat.
I love it. Okay, Delvin, you ready?
Yes.
I'm going to start with you. So our first question, Delv, is how would you describe anxiety from your perspective?
For me, anxiety just feels like a very uncomfortable feeling, like deep within my chest and deep within my head. For example, when I go to a mall and there's tons of people there, I start to get like a bit feeling woozy, like deep within my body, and it feels like I'm about to faint. Like all I can think about is just getting out of there. And to me, that is what anxiety feels like to me.
Okay, great. So pretty intense, Delvin. It sounds like you have a full body experience. Yeah.
It's
Okay.
it's something that like it took a long time for me to get rid of, or to uh something to understand, and trying to relax my head and my body.
Well, you've done some beautiful work at Evolve in terms of, and I love that you said about recognizing, because it really is so much about that, catching yourself and understanding it, which you're doing such beautiful work in that. Awesome. Mackenzie, would you let us know how anxiety has had an impact on you and your goals and your life in general? I know it's a big question.
Yeah, and anxiety has impacted a lot of my life, school life, social life, career life, it's a lot of roadblocks in my way. They stop you from going forward and giving you setbacks that you kind of slowly have to kind of, grow over, or like, I'm not like, I don't want to say get used to, because it's not something you should get used to, but it's something you do have to kind of live with.
Right. Thank you, Mackenzie. I know this has been something that you've been focused on for quite a long time. Yes. Okay, beautiful. We're going to come back to you in a minute, Mackenzie. Anna, we'd love your perspective. We have a lot of parents here, and it's really important that, we hear from you in terms of what do you think that would be the best thing to tell a parent who has a child who has anxiety, when it comes to really understanding and how to support them.
Right. So for me, anxiety is kind of always there. I could compare it to white noise, where it's always in the background. There's been a lot of times where I've worried over something that doesn't really need to be worried about, and it might sound ridiculous to worry about it, but it also doesn't change the fact that I am still worrying about it. So what I find helps is I need patience from other people. Sorry, let me get back to my notes. From my own experiences, when someone has told me that it's going to be all right, or everything's going to be fine when I'm worried about something, it's never really helped, because it feels a bit invalidating. I understand that my worries sometimes, okay, a lot of the times, are way too overblown, but it doesn't change the fact that I'm still really anxious. And patience has really helped. And processing it with another person helps, as in narrowing things down to facts, like black and white information of, okay, so how realistically is this thing you're worrying about going to happen? What are like the percentages, the odds?
Okay. So that in terms of, I love what you said. One is that patience piece. And the other thing is that so you feel validated that, no matter how unrealistic it may be, the fact that you're just saying, you know what, this is how it is for me. So I just need someone to actually listen. And the strategy you're talking about is facts. of looking at
Yeah,
the
my
evidence
my
to
brain
support.
really likes facts that are there's a solid yes or no, so it's easy to think about.
Great. Okay, thank you for that. Mackenzie, do you want to take this one? And what advice would you have?
I mean, my best advice is for a parent to know that it will be a struggle when you have a child with anxiety, because just like with my parents, they had to struggle a lot too. They still struggle even though they do know what's going on. There's nothing you can really do to get rid of anxiety. It's not possible to go away. The best thing you can do is always just be there for your child. Just always know that, let them know you're there for them. That's the biggest comfort any child can have when they're going through something so huge.
So Mackenzie, would you say, like similar to Anna, the idea of being there and listening and just validating the feelings?
Yes, even if you don't understand what they're talking about, because even my parents to this day are sometimes like, what is she talking about? She's losing her mind. And it's like, you just kind of got to go along with it. Sometimes it's better to just agree with them because it makes them feel better, or sometimes you just want to reassure them.
Yeah, I think as parents and people who are working with individuals with anxiety, there's that tendency to want to fix it, come up with a solution. And what we're hearing from you is, no, I just want you to let me process. Yeah. Okay. Thank you for that. Delvin, it kind of goes
Yes.
back to what we're talking about in terms of strategies. So what has helped you? What strategies has helped you reduce your anxiety?
As I get older, I can feel my anxiety has gone down, but it's still in there. So one of the strategies I use to help me not focus too much on my anxiety or stress is that, like, for example, when I go to a store again, instead of focusing on the people around me, I try to focus on maybe my grocery list, like focus on important things I need to buy, or maybe focus on think things like I might do later that like less stress inducing, like play games or spend time with my family. Um, and other strategies I use is the ones I learned from Evolve, like deep breathing or thinking positively. Anything that helps. That's um that's what I do. That's what I use to help reduce my stress and anxiety.
Not so much about mindset,
Mm-hmm.
in terms of, right? What do you think?
Yeah. It's just I feel like there are so many ways to help reduce not get rid of anxiety, but help not make it the main focus in your head.
Mhm.
Mhm.
Beautiful. Thanks, Del.
Mhm.
So Anna, coming back to you, um, there's when we think about autism and anxiety, Sonia and I, because we work with so many young adults, we see this correlation so much. And so we would love for you to just kind of articulate in terms of how do you feel that having a diagnosis of autism is related to your experience with anxiety?
Okay. They are definitely related. For me, there's never been one without the other. This translates into anxiety everywhere. Basically, my processing speeds are different than a lot of the people around me. And especially in school where everyone was going through school, having a great time, doing it easy, and I was in the background. I had no idea what was going on. I didn't understand why I wasn't able to do the things that other people did. And wait, no, sorry, I got off track.
You're great.
I had a thought and then that thought took over.
Well, that's honest.
Let me look back at my notes again. Okay, anxiety and autism. This translates more into social for me. Case in point. I tend to overshare about myself to relate to the conversation. And then I get really worried that people get unnerved that I overshare. But the thing is, I don't really know what else to talk about. Autism, as you know, can come with some social difficulties. And for me, that's a reduced social battery. And when it runs down, I have to stop, or things don't end well. Social. Sorry, I got off track again.
That's okay, but I love that you're talking about social battery, right?
Yeah, and even if I had a great time with people I absolutely adore, I will still be tired at the end of it. The connections that my brain makes in social things, I'm so sorry. I have really lost my train of thought.
You're doing beautiful, Anna. And I think that the way that you've described it to us too is your brain's working overtime and trying to find relevance, right? And where you lines up with people. And so that brings the cognitive fatigue, which causes more, right?
Yeah.
That's okay. You made that beautiful point. So think if there's anything else you want to add on, that thought process comes back in, just say, oh yeah, I remember what I wanted to add. So just take a breather. And it's okay. All right.
Yeah.
But what you said was so poignant and really important. Ivan, hi.
Hello.
So Ivan's been, we're just so excited for you, Ivan. Ivan auto body repair, and Ivan's in an apprenticeship right now and has worked so hard and is going to be employed in June, right? Which is fantastic. And so it's a very technical job, right? With a lot of details, and you have to have so much knowledge, and you've been doing such a beautiful job. One of the things though, we know when, you shared when you get new tasks, right? And there's that expectation of doing things right, that it causes a lot of anxiety. So can you share with us basically what strategies you use when you are faced with anxiety at work?
So when I face anxiety, it happens, many things happen to me. One thing for sure is that I overthink. It makes me out of track. I can't think of anything. It makes me panic a bit. Yeah, it does. And it does all the time. But what I would say a strategy for me is, there are sort of two things for me. One is music. Music is one of the biggest things for me. I mean, tons of people hear it. I love to hear it. We at work, my boss has a stereo, a speaker where we can hear music. He likes music too. He plays all the time. We hear music and we're good. We're good. The second one will be when I am like struggling to finish work and I'm thinking of what the next step is. I stop, take a quick breath, and start over. Because if I keep continuing, either can not move anywhere or I'm gonna mess up on the way. So yeah, that's one of my strategies for that.
That's beautiful. All right. Did you want to add any more?
I think it's like what Elvin said. Over time, it will get better. It will get better. It'll still be in you, but over time, it will get much better. You get used to it. You get used to work. Then you know the routine. Then you know in your head. over time it will get better. It will get better. I mean, it sort of impacts as it keeps going, as you keep going through the motion. Like when you meet your first person, when you first met that person, next thing you know, a few years later, that person is your best friend.
It's true.
So I would just say that if you're willing to go forward and keep going forward, but if you're gonna stop, I say stop for a moment. Don't go back. If you're gonna go back, then you're not gonna move forward, and then it'll get up worse. So I think stop, take a break, and then keep going forward.
That's such excellent advice. Ivan, thank you for sharing that perspective.
You're welcome.
We have one more question, and Mackenzie and Anna both wanted to answer this question. And this is about self-advocacy, which is a massive, important skill in anything that we're doing. So what do you feel, what self-advocacy skills do you feel are the most important when explaining and helping other people be aware of anxiety? Anna, do you want to start?
Sure, yeah. So what really helps me when I need to ask help for things is to help combat the anxiety. I really appreciate getting information ahead of time so I can have enough time to process it and sit with it to understand what's happening. Direct communication is key for me because I process things differently, and I might, like, for example, if you're giving directions and someone says, okay, turn there, I don't know what there is. Does it mean right? Does it mean left? There are multiple different ways it could go. I have no idea. So specifics are the best for me. Predictability, again, making a routine, knowing what's coming next. What has stopped me from asking for help that I really have needed is that because I feel that I've already been such a bother with all the help I've needed before, and I've already caused so much trouble. So if I ask for more help, I'm just going to be more of a bother. And it's taken a lot of time to understand that asking for help is not a bad thing. It's a neutral thing of you need help, so you get it. I'm still working on that, honestly. But yeah,
Nice.
it's really nice to hear reassurance that asking for help is not a fault. It's just taking care of yourself.
That's a t-shirt, Anna. All right, Mackenzie, what do you think? Self-advocacy.
I mean, yeah, going off what Anna said, where you think you're a bother and stuff, and like, especially when you like need help but you don't want to ask it, because the biggest thing I think for us is fear of rejection. It's like you may come up to us and say, ask me if you need anything, and I'll be like, okay, and then never ask because I'm terrified to do it. You may be like, I'm here for you. I'll be like, thank you so much, but I'm like, I don't want to bother them. I don't want to bother them. And it's like, you can't really help yourself if you're not asking for the help.
Yeah, it's beautiful. Beautiful. What a great way to finish this. Thank you so much, Delvin, Anna, Mackenzie, and Ivan for your perspectives. Sonia, is there anything in the chat that's coming up that you think would be?
Yeah. So first of all, you've got a lot of really positive feedback, Delvin, Ivan, Melissa. Mackenzie, I just called you Melissa. Do you like your new name?
I mean, first it was Meg, now it's Melissa.
Now it's Meg, Melissa. And Anna, I think for individuals that are experiencing anxiety, it's lovely to feel like you're part of, you're sort of speaking for individuals who maybe don't get that opportunity. So that was you got a lot of compliments on that. One of the things that was asked in the chat is, you know, an individual who maybe isn't as verbal, because you're all fair, you know, really articulate, right? But as we know, in the autism spectrum, there are individuals who do not develop, or it's really difficult to have verbal speech. And so one of the questions was, do you think that there are strategies and ways that an individual who maybe can't articulate or can't ask us, you know, verbally, maybe could get the same kind of support or express their needs? And I just wondered if you had any experience with that, or you have any comments on that, and then Robin and I can comment too. Do you want to, Anna?
Yes.
Okay, go for it.
In the Evolve program, there is an amazing guy who communicates through what's it called? It's on his iPad, and
yeah, it's like touch chat.
Yeah, it's there's words and he presses them and it forms sentences. He's in college and he's doing really well. Just because you can't form words or communicate differently than others doesn't mean that your brain is messed up.
If anything, he's smarter than
he's
me.
got it. And he communicates really well through typing. And I also find that even though I'm fine with words, I also communicate a lot better through typing because my brain moves really fast. And when I think of one thing, it goes off into 87 other things. So the thought to word translation gets all jumbled up. And with typing, I can keep up with my thoughts. So it's a lot easier to get across what I'm trying to say.
So I mean, Anna, I know sometimes it's helpful, like when you and this young man in the program, you type back and forth sometimes to each other, which I know is one of the other questions, which actually I don't know who wants to answer this, was from somebody asking, look, I take medication, right? And I have anxiety. You know, his question is, do I need to become friends with my fears and not let them overtake me? Or shall I make friends with my anxiety, just work on it? Or should I still take the meds for it? So I think sort of the question really is about how much do the meds help? And are the strategies more important than the meds? Are the meds more important than the strategies? Or do you feel from your experience that to some degree you maybe benefit from both? Does anybody want to take, Mackenzie, do you mind taking that?
Yeah, I take anxiety medication.
Yeah.
I started taking it when I was like a big, huge anxiety panic attack kind of thing.
Yeah.
And it is significantly very helpful.
Uh-huh.
But there are still times where you want to use your coping strategies, which is deep breathing and stuff.
Yeah.
I would say both of them benefit you very well, and neither one is more important than the other. Because I think both are needed.
Both are needed. Okay. Yeah. Wonderful. Anybody else want to add anything into that? Yeah, Anna?
Oh, does Ivan want to go first?
Oh, no, you go, Anna. You're good.
Okay.
Oh, you're being so polite. What's going on with you?
Oh.
You're doing turn taking. Excellent.
Wow. There's been a lot of times where I've wanted to toss my meds away because I get angry that I have to take them. I get frustrated. But in reality, they do help. There's never going to be a cure-all medication you can take. It's another piece. It's a building block, basically. It's not the whole structure, but it still helps. And sometimes you have so much anxiety that the meds can't work with it by themselves, so you do need other strategies.
That's beautiful. Thank you for that. Ivan, I know you wanted to add, did you?
Yes.
Okay.
Well, I personally can't tell my perspective because I don't actually take like meds or anything like that. But I would say I this might be a big step, but try going one day without them. I'm just saying try it. You don't need to do it immediately. I'm just saying try it out, see what you feel.
Mhm.
If it works for you, that's good. If it doesn't, then you can keep going on them. But
Mhm.
the reason why I don't use them is because I don't want it to take a hold on me. I don't
Got
want to. It's like a string hanging on there. I don't need to crave for the med just to calm myself down.
Got it.
Anything could calm you down,
Yeah.
whether it's a pad, whether it's a phone, whether it's a gaming, whether it's exercising. A lot of people use that just not to take meds or anything like that.
Mhm.
All I'm saying is to try.
Yeah. So
Try
Ivan,
it.
you're just saying that everybody's different and you sort of have to try out what works for you. And some people, medication could really help because it could help them access their strategies. And for you, you want to you're just looking at it from another angle. Beautiful. I really like the questions. We didn't have any others. We just had a lot of compliments for you guys. And I personally just wanted to say before Robin finishes, thank you. I so appreciate you being on today. Robin?
Yeah, this is really great, guys. And our panel ends at 12:30, so your time management is
Yeah, we did
it's
it.
beautiful. And thank you everybody for your kind attention. Thank you, panelists. Thank you, Sue.
All right, thank you, everyone. And thank you, Sonia and Robin. It's always such a pleasure having you in our conference. And thanks to our self-advocates for sharing your personal stories. Very inspiring. So with this,